Are we ready for the next case, my
Sure.
chair?
I will. I will present the next speaker. Next speaker is Dr. Hamid Alghamdi from Saudi Arabia. Hamid, you can start your presentation.
This is Hamid Alghamdi. I'm an interventional cardiologist from the Eastern Province in Saudi Arabia. I'd like to start by thanking the GIS team for the opportunity, and I'm happy to share with you today a case which I call left main case. Be careful what you wish for. So straight to the case, this is a 58-year-old gentleman with long-standing history of diabetes, hypertension, dyslipidemia, peripheral arterial disease, cigarette smoking, and he was unfortunate to have stage 4 chronic kidney disease due to diabetes with an estimated GFR around 18. He has been complaining of long-standing history of chronic angina with evidence of significant ischemia on PI, which was reported as high risk. And I guess the issue of end-stage renal disease complicated his management. I initially met the patient back in 2017. He presented with worsening exertional symptoms despite good medical therapy. As I said, he had previous evidence of significant ischemia on MPI, was done back in late 2015 or early 2016. Echocardiogram showed preserved function. And after a very thorough discussion with the patient, we elected to go ahead with angiogram invasive management, understanding all the pluses and minuses of such approach. So we opted for minimal contrast intervention or strategy. So we started with an angiogram which showed the total occluded RCA tight mid-LAD lesion and mild proximal LAD disease. Then at a different session, we did IVUS-guided PCI to LAD with 2 drug-eluting stent, and luckily his renal function did not change. We were planning for complete revascularization, but unfortunately he declined stage PCI to RCA CTO due to his chronic kidney disease, as he couldn't accept an additional risk of potential dialysis. So he continued on medical therapy. He did fairly well for the next 1 or 2 years, although he did admit to some symptoms of moderate exertion on optimal therapy. But later on, he developed paroxysmal atrial fibrillation with worsening volume overload. He was quite resistant to starting hemodialysis, but eventually he succumbed to the fact that he needed dialysis, and it started somewhere back in 2019. So he did okay over that period, but he presented again in 2020 with worsening exertional symptoms despite good medical therapy. A repeat echo showed preserved LV systolic function. And knowing his history and his RCA CTO, opted to go for invasive management. Repeat angiogram showed RCA CTO, patent LAD stent, and a significant progression of his proximal LCX disease and mild distal left main disease. So we went ahead and we did IVUS-guided PCI to RCA CTO with multiple stent, and we planned to stage PCI to the circ. This is the angiogram. You can see the mild disease in his distal left main and a very tight proximal circ, patent stents in the LAD, and quite favorable anatomy and angle. So what's next for this gentleman? Now, I must admit that I was quite optimistic, as I planned actually for a very minimalist approach. As you can see, I decided to go ahead, giving the minimal disease in distal or mild disease in his distal left main and the favorable angle, as well as what seems to be free LAD ostium. So I decided to go for provisional stenting of his circ. I pre-dilated with 2.25 regular balloon, and because the outcome wasn't encouraging, I went ahead and did more pre-dilatation and preparation of the lesion by 2.5 NC balloon, and this is the result. And you can clearly see that the ostium of LAD did not change, and the distal left main also remained in good condition. So I decided to go ahead and put the stent. And after very meticulous positioning of the stent, eventually I managed to put it to crowd the ostium and to hopefully land it at the ostium, sparing the distal left main. Unfortunately, plans didn't go as I wished, as during inflation of the stent, it is slid backward into left main. And as you can see on the left-hand side loop, that the marker actually moved back into left main, which I think was about 3 millimeter or so. On top of that, you can clearly see that the ostium of the LED is now different. You can see that there is some narrowing of the ostium. Doesn't look severe, but it certainly looked concerning. And that, not to mention that the stent obviously would require further optimization. I was very concerned at that time regarding the ostium of left anterior descending artery. So at this stage, I had to revisit my plan, and as I had a bailout strategy in my mind. It would have been nice actually to discuss it before I go ahead and do it, but given that I had to record this presentation, so I'll go ahead and tell you exactly what I did. I needed to understand what happened to the LED ostium. So obviously I just secured it with a wire, and I went through the struts. I slightly dilated the struts so I can advance the IVUS catheter and to have a proper IVUS assessment. And this is the IVUS loop. Started with the mid LED stent, looked well opposed, and you can see some calcification here and there with some mild to moderate atheroma. But towards the ostium, you can see more disease right there. Then you can see the stent in distal left main. This is a short view. I'll just stop it so I can show you that actually the around this is just before left main. You can see a significant, well, there's an arc of calcium from 12 to 3 and significant atheroma. And I was quite worried that if this is the case with the implantation, likely it would get worse with optimization of the stent. So I decided actually to go ahead and adopt the bailout two-stent technique, and I opted to go with the inverted Kilot technique. So I dilated more than I placed 4 by 30 millimeter onyx stent, and it was difficult to recross into the circ, so I had to do initial pot. Then after that, we crossed and did aggressive post-dilatation of both the stents, then eventually finished off with kissing balloon inflation and pot with 4 or 5 NC balloon to the left main part of the stent. This is the final IVUS after all the aggressive post-dilatation and kissing inflation. You can see well-opposed LED stent as well as well-opposed stent into left main. And this is the final angiogram that looks actually quite favorable. I was happy at that stage. So just to sum up, I'd like to say that reliance on angiographic assessment of left main or ostial LED or circ, the same matter, could be misleading, as we saw that the ostial LED probably had more atheroma than I anticipated. Therefore, IVUS interrogation is a must, and we should obviously plan our strategies ahead of time and with initial strategy, and we should always have a bailout strategy should our initial one was provisional stenting and did not fulfill our initial required outcome. Thank you so much.
Thank you, Hamid, for showing a great case with excellent intravascular ultrasound. That really shows that if you have done intravascular ultrasound up front, your strategy would be different. And I think that's the best lesson we are learning. I think I'm actually happy that we have COVID. Because of COVID, our volume has gone down worldwide. Every country has shown 38 to 40% reduction in cath lab volume, especially in elective cases. That is giving us more time to do IVUS in the cases we are doing. And we're learning a lot more. I have never done an IVUS that I haven't seen something that changed my management. And I think your case is an excellent example of that you would have gone with the two-stent technique anyway, had you seen the IVUS first.
Absolutely.
Hamid, beautiful case indeed. When you did the IVUS and the IVUS catheter did not pass easily and you had to re-dilate to get it in the spot where you wanted it to be, and the ostial LAD has a good bulk of calcium, and you did the beautiful job stenting the area. Did you think about debulking at that particular stage to make sure that you get good expansion? Yeah.
But for the circ stent, you mean?
Well, actually, when you did the pullback from the LAD towards the left main, there was a good bulk of calcium.
True.
Yeah, so I was wondering, because at that time you went ahead and stented, beautiful job, obviously, but would you have thought about debulking first?
Well, yeah, but tell you the truth, I didn't have the appropriate size for left main. That's one of the issues. So I just I thought, knowing that the greatest diameter was close to 5, I can just probably get away with aggressive, pre and post dilatation with NC balloon, and that's what I did. And the final IVUS showed that I had a very decent and satisfactory position of the stent towards the distal left main, and I just left it there. But yeah, definitely debulking these cases would, I think, in the long term, make a difference.
I have to message from our organizing team. We have to stop right now because we have a live case, and I encourage everybody to join the next session, which is a live case from Mount Sinai Medical Center. So please stay, live case from Humanitas Hospital, Milan, Italy. And please join the live case session. Thank you, and we will close this.